Hello, cosmonauts. Today we are going to be exploring what Reddit Ask to Doctor of Reddit had as the biggest medical mystery you've solved. Answer 1. Not a huge mystery, but one that drove me nuts for 4 years as a dentist was this guy who had severe acid erosion on all his teeth, but one area in particular was super bad. I figured he had to be obsessively eating something acidic and chewing it with one side of his mouth. I would interrogate him at every single visit, and there were tons of visits because he was totally destroying his teeth, to figure out what the hell was causing it. I probably asked the guy 50 times over 4 years if he liked to eat sour candy. Always said not really. One day we had a long appointment together, and I just decided to name every sour candy I could think of while I worked. Captive audience. When I said cry babies, he was like, I like those, they're so sour. Come to find out he was eating 1 to 2 bags a day. Dude, what did you think I was asking about when I asked if you like to eat sour candy all of these years? Answer 2 Namibian dollars, but saw this. Patient came with constant hiccuping that wouldn't go away and dizziness spells. Initially, they were told it was just hiccups and should go away, but it didn't, and it was constant. Their primary care and urgent care physicians kind of blew them off and racked it up to nothing. They wound up going to the emergency room who did a chest x-ray to rule out some kind of weird origin. So anyways, this patient had a permanent pacemaker placed some months ago. Chest x-ray showed the wire that goes into the heart to pace them had punctured the heart, gone outside of it, and looped its way around to the other side and was sitting partially against the vagus nerve. Their constant hiccups were from their dislodged pacemaker causing pulsations to the nerve that controls their heart rate and breathing. They wound up having the troubled lead wire removed and replaced, and their hiccups and dizziness were fixed. Answer 3. I made something up on the spot that saved a guy's life. Motorcycle crash. Dude comes in agitated, breathing rapidly, has the "I'm dying" look in his eyes. We intubate him for low oxygen levels, and it's just not working. The tube's in the right place, but now he has 2 massive pneumothoraxes, collapsed lungs, and with every breath he is pouring air out of the chest tubes I placed. Air is going in, but not making it into his lungs. There's an airway injury somewhere, and it's big. I tell my ED colleagues to get a bronchoscope ready because we're going to do the fastest CT ever and figure out what's injured. Edit. A bronchoscope is a tiny camera on the end of a long, maneuverable tube. Same concept as a colonoscopy scope, just smaller, about the thickness of a pencil. He barely survives being in the CT scanner. We get one pass through and speed him back to the ED so we can figure out the next step. As the CT images come across, it's worst case scenario. His trachea is completely severed, and forcing air to go through has created this large, air-filled gap in his neck meat between the 2 ends of his windpipe. Every breath we force in there takes the path of least resistance, meaning into the chest cavity and out the draining chest tubes, but not into his lungs. So basically, he won't survive long enough for us to try and surgically fix it. But if we could just push the breathing tube down to the lower segment, we would be able to help him breathe again. So in a moment of inspiration, I tell my respiratory tech to set up the bronchoscope. I stick the scope in the breathing tube, like usual, and have the ED doc helping me pull the tube most of the way out. And there it was. Once the ET tube was pulled back, my bronchoscope was basically sitting in what felt like a giant cavern of neck meat, all stretched out from forcing so many breaths down the ET tube. And at the end of this cavern was the other end of his trachea. In reality, this cavern was probably 15 millimeters wide at the most, but I was locked on and drove that bronch straight down the middle and into the lower segment of his trachea. Once I had the scope in, I basically rammed it as far down into his lung as it would go, and the ED doc rammed the breathing tube over the bronch, down into the lower segment. We pulled out the bronch and gave a few breaths. There was no leaking. His chest rose with each breath. His oxygen was back at 100% within 45 seconds. We got him up to the OR, and about 6 hours later had fixed him up, and he survived that night. The best feeling, though, is when a renowned otolaryngologist whom we called in to help with the tracheal repair asked how I got the tube down into the lower part of the trachea. I described what we had done in the ED, and he just goes, "How? That's not a thing." Answer 4. Diagnosed lupus cerebritis in a patient who was basically comatose after being on ECT for depression for a couple of years. I think she still had some underlying psych issues, but improved significantly after starting high-dose steroids. I was consulted as a resident on the ID service and noted the patient had persistent proteinuria and had been seen repeatedly for joint pains. My attending said we should sign off after the lumbar puncture was negative for infection, but I convinced him to let me order lupus labs before we signed off. Answer 5, psychiatrist here. In residency, I was moonlighting at a standalone psych ER. A man who didn't speak English was brought in by emergency services for psychosis. With some interpreter help, we were able to identify he was from Bhutan and that he had been a freedom fighter. But the interpreter said that he spoke very little that was comprehensible. I noticed some tattoos that seemed amateur and possibly from his time in combat. It dawned on me he could have hepatic encephalopathy from Hep C. I arranged transfer to a medical ER. They were pretty upset with me about it. To their credit, they called back later that night to confirm I was correct, leading to a plan of appropriate medical care instead of inappropriate psychiatric care. Answer 6. A cool call I had as a paramedic many years ago immediately annoyed my partner and I. 20-something-year-old male woke up with nausea and vomiting Sunday morning in a neighborhood that is known for young people partying. The call notes said there was a small amount of blood in the vomit, so it got up triage to paramedics responding. We arrive and are met by the patient's girlfriend, who is freaked out but guides us to our patient, who is white as a sheet, drenched in sweat, vomiting all but pure blood into a trash can that is already pretty full of blood. We start our assessment and treatment, and he has a vague medical history. He has always had digestive issues and has to eat a diet with extremely low fat. He has chronic diarrhea and really bad hemorrhoids. We ask about what he got up to last night and if he was partying. He says no, he can't have more than a beer under any circumstances, or he's a mess for days on end. He smoked a little weed, but not more than usual, and he smoked from the same bag earlier and was fine. He has never thrown up blood before. He'd never done more than go to an urgent care for his issues before, as he didn't have insurance. Obviously, he has an upper GI bleed, but something clicked in my caveman brain and realized exactly what was happening. His liver was screaming for help, can't digest fat, can't process alcohol, and what seemed like an innocuous comment was the key to the whole thing. His hemorrhoids. If the circulation through your liver gets backed up, it causes pressure in the blood vessels that come in and out to build up. If enough pressure builds up, the veins in your butthole balloon out, causing a hemorrhoid. If that pressure goes north, you can get esophageal varices, which are essentially the same thing as hemorrhoids, but in your throat. They can rupture and bleed like an absolute son of a bitch. Despite our efforts, he had lost a ton of blood and rapidly got worse. Upon arrival into the critical section of the ER, he painted one of their walls, passed out, and needed to be intubated and given many blood transfusions. The attending, head doc in the ER, had always been an aloof dickhead who didn't play well with nurses nor EMS, but after the dude's liver labs came back and we were back later in the day with another patient, he pulled me aside to be like, "What exactly is the scope of your guys' training? That was crazy that you caught that." I reflected on that moment for the rest of my career, during which I felt like an absolute moron about 90% of the time. Answer 7. Shout out to the doctor who recognized that my toddler had leukemia. She had an ear infection with a low-grade fever that her PCP had treated with antibiotics. A week later, we took her to urgent care because she still had the fever whenever Tylenol wore off. The infection was gone, but she had been developing a lot of bruises in the weeks prior. Her PCP had dismissed the bruising when I asked if it was something to worry about. Some kids just bruise a lot, but the doctor at urgent care noticed she had bruises on her back and sent us straight to the ER for a CBC. We are 9 months into treatment and doing quite well now, thanks to her. Answer 8. My kid was born with a rare lung disorder called congenital lobar emphysema. At the time, less than 50 cases had been seen in the world. Son shouldn't have lived past 2 weeks, but our pediatrician finally diagnosed it at age 5 months. Son had surgery, left upper lobectomy. The following year, our pediatrician was at a huge conference with around 700 MDs in attendance, and the speaker threw out the symptoms for my kid's disorder. Only 3 hands in the room raised to acknowledge they knew the diagnosis, and one was our pediatrician. Answer 9. Not a doctor, but a genetic counselor who works in pediatric oncology, and it's less of a "what could this be" and more of a "trust your gut" situation. I saw an infant with a brain tumor who I was originally told had no family history of cancer, but upon talking to mom actually had breast cancer in her 20s, and her mother had a rare sarcoma and died in her 20s. Moreover, all of their maternal relatives had cancer at young ages. Interestingly, all genetic and tumor testing for both the infant and their mom was negative thus far. Usually in that case, we say, "We don't know every cause for cancer yet," and leave it at that. But the plot twist of the family history was extremely suspicious for one particular cancer predisposition syndrome. So I couldn't in good faith just end things there. I ordered a single gene test on a whole genome platform, which sequences far deeper into the gene than any other test does. Labs don't sequence that far because it's extremely rare to find anything there in the intron, which scientists used to believe was junk DNA. because introns don't get translated into protein. Sure enough, test identified a mutation deep within the intron of this gene. It's absolutely the explanation for the child's brain tumor and his family history of cancer. Certainly a devastating result, as this cancer syndrome is associated with a 100% lifetime risk for cancer of almost any type you can think of. It's called Li-Fraumeni syndrome, if you're curious. However, I'm so grateful to finally have an answer for this family, because we can ultimately pursue intensive surveillance for positive relatives that will quite literally be life-saving. And of course, this fuels my paranoia of, is a negative ever truly negative, and intensifies my desire to dig deeper for these kids. Answer 10. Not a doctor, but a nurse. I had a patient that had been struggling to find a medication to help with her anxiety and depression. After a couple of years of trial and error, we found a med and dosage that worked extremely well for her. Time goes by and she suddenly starts having symptoms again. She said, "I don't know what's happened. The meds were working so well, and now I feel just as bad as I did before I started medication." We spent several calls and visits going over every single thing, just grasping at straws. Has your pill manufacturer changed? Do the pills look different? Has your diet changed? Increased stress? Exercising more? Anything. Finally, I asked her if she had recently started any new medications prescribed by another practice, and she suddenly remembers, "I started metformin about 6 weeks ago." I think to myself, that's it. I asked her, not to be gross, but are you having a lot of diarrhea since you started the metformin? She goes, "Yes, I'm pooping several times a day. I can't keep anything in." I then explained to her that the problem was, she wasn't absorbing her depression meds, she was pooping them out. So not only was she not getting the benefit from the meds, she had been going through med withdrawals too. She talked to the doctor who started her on the metformin, and he switched her to metformin ER and changed the timing of when she took both meds. 2 months later, she was back to feeling good again. Answer 11. I am not a doctor, but one saved my life by a simple handshake. I was in hospital with gallstones. I was prepared for surgery, saw my surgical team, etc. All good. We are taking you up for surgery. I felt absolutely rubbish, but put it down to anxiety and the pain from the gallstones. The doctor was in the room to see the woman next to me. He was Irish, and I am Irish, both outside Ireland, so we picked up on the accent and had a little chat, as you do. As he was leaving, he went to shake my hand. He walked away and came back, questioning me that my hand was extremely sweaty. I explained that I have anxiety and it was going off, but he was not convinced. Thanks to him putting up an argument that my surgery should not go ahead, and I need scans. My scan was canceled 3 times, but he kept on pushing it through. I was diagnosed with multiple bilateral PEs. Hey you, if you're enjoying the video, subscribe for more histories. Answer 12. Not me, but my attending. We had an older guy with new severe hip pain, but his X-ray and MRI was normal. Things were just off, and she felt like there was more going on. We got an MRI of his spine, and lo and behold, he had a huge honking spinal abscess. Most of the time, you would expect to see weakness or sensory changes with a spinal abscess. He had none of that. We imaged his whole spine and found a couple more spots of infection. So we imaged his brain. Big old abscess. We also got a heart ultrasound, echo, that ended up showing a massive infection sitting on one of his heart valves. He had literally 0 symptoms except this sudden onset hip pain. Long story short, we think his bad diverticulitis let some bacteria into his blood, and he was unlucky enough to have it seed his heart valve. He ended up doing great with a truckload of antibiotics. Answer 13. Not a doctor, but giving kudos to my daughter's doctor. At age 5, she had a tummy ache that seemed more than normal, so we took her to urgent care. They sent her home and thought it was a rough stomach bug. She wakes up the next morning and doesn't want to move. From the time I could feel her kick until she came out, she was constantly on the go. So we took her to ER. Doctor tested her on heel drop test suspecting appendicitis, but she passed. So he said he wanted to run a blood test because he had a suspicion but was unusual. Blood test comes back, her pancreatic enzymes, I think, were off the charts, which is what doctor had suspected, pancreatitis. She spent 5 days in one of the best children's hospitals in Colorado, no underlying cause, which is extremely rare for a child, 2 to 10 cases per 100,000 children, and made a full recovery. How that doctor suspected it, I have no clue, but very grateful for them. On a side note, she was transferred to the Children's Hospital main campus, which is also a teaching hospital, and it was fascinating to see the process. Because it was such an unusual case, we had anywhere from 3 to 5 residents come in each morning learning about her, asking the head doctor questions, etc. Our last day, the department head came in to talk to us about how unusual her case was, that we would likely never find a cause, and how difficult that may be going forward. But such is life sometimes. She is now 12, going on 18 as it seems, and hasn't had a problem since. Answer 14. Not sure if this is a mystery, but I connected the dots as a resident, 8-year-old kid that presents to ER with fever SOB, and a small lower leg wound after falling while running 2 days before. He also wasn't wanting to walk much due to pain from his leg. Everyone had assumed his wound, but when forced to ambulate, he had a bad limp. I was in last year of MedPed's residency. I presented the patient as fever from a septic hip 2-2 from his leg wound, shortness of breath and fever from pulmonary embolism also. This was my guess before labs and CT based on physical exam. In the end, I was right about everything. I was just trying to be a smartass because I had a good relationship with the attending, and PE in kids is way less common than adults, so I thought I would be more obnoxious throwing in the PE part. It was humbling because I was just being obnoxious, and it made me think about what I've missed before, not turning over rocks. Similar situation years later with an elderly woman with anemia, GI bleeds, and aortic stenosis that my partner ran by me. She had been scoped by GI and been to heme with negative anemia. Workup, cards didn't think she warranted valve replacement. Patient kept getting passed and my partner was getting frustrated. Being his ass, I asked if anyone had considered Hayes syndrome. I told him, put that in your note and send her back to cards. She underwent valve replacement. No more bleeding, no more anemia. Answer 15. I'm the patient here, and I have a few rare diagnoses, but I'll tell you the one with the more interesting story. See if you can guess the diagnosis before the end. It's an atypical presentation. At around 19, I began getting a lot of UTIs. Months later, I realized that I can't feel when my bladder is full. I go to a urogynecologist and do urodynamics testing that confirms the nerves to my bladder are indeed dead. I have a slight herniated disc, so it gets attributed to that. I develop really bad sciatica, and my feet would go numb. I wind up in pain every day with significant muscle spasms in my lower back and down my legs, which is typical for a herniated disc. One neurosurgeon wanted to operate, but when I got a second opinion, he explained that my herniation shouldn't be causing these symptoms because it's very slight. I get referred to PT, but PT seems to worsen my symptoms. They told me they could no longer help me and discharge me as a patient. Years go by. My pain and numbness only worsen. Finally, the pain spreads to my abdomen and reaches a point where I am bedbound almost all of the time. I just so happened to be seeing a reproductive endocrinologist for fertility issues at the time, and they just so happened to have one of the best endometriosis specialists on the East Coast on staff. She recommended a laparoscopy on a hunch, and she was right. We operate, and there was scar tissue everywhere. I wake up with no more sciatica or muscle spasms or pain. That surgery completely changed my life. I had never had bad periods. I barely even cramped. I had sciatic endometriosis primarily, and if I wasn't seeing that exact reproductive endocrinologist, I may never have had it treated. Answer 16. I work in dermatology. I had a patient who was experiencing delusions of parasitosis. They literally think they have bugs crawling on their skin. It's a somewhat common psychological disease we experience in dermatology, and most of the time, it is 100% psychiatric in nature. Patient reports that he swears that he got the bugs from a sexual partner. Physical exam on the genital area shows no abnormalities, and he has no skin abnormalities. So I run an STD panel. Long story short, he has neurosyphilis, and I had to send him to the hospital infectious disease for some heavy doses of penicillin. Syphilis definitely has the reputation for being the great imitator. Answer 17. Not the doc, but I was taking care of a patient that was hospitalized for multiple days because of crazy swings in her blood glucose. The docs couldn't figure out why 1 minute she'd be cruising well over 350 and climbing, and 20 minutes later it would crash into the 40s. She was nothing by mouth for reasons I don't recall, possibly a gastro infection. So we were pumping IV dextrose multiple times a shift to keep her alive. We were literally down to our last vial, including robbing the crash cart on my unit and the ER, and I was freaking out because I was working alone that night. It was a rinky-dink rural outpost hospital. One doc in the ER on call is needed for my unit overnight. No real support besides calling EMS to transport to a larger hospital over an hour away, and I was afraid of losing my patient. In between this patient's crises and other patient care, I did a deep dive on the interwebs and found a research paper that discussed how some diabetics respond that way to certain classes of antibiotics. I let the hospitalist know in the AM and provided the link to the paper, but never got a response. I was off the next night and the patient was gone when I came back for my next shift. I was afraid she died, but was informed by the outgoing shift that she discharged home because our hospitalist figured out it was the antibiotic causing the chaos and switched meds. And immediately her blood glucose stabilized, and with the new antibiotic, the infection was brought under control. Answer 18. Obligatory. Not a doctor, but my daughter was medevaced by helicopter to the nearest PICU at 5 weeks old for hypothermia and suspected sepsis. Even on antibiotics, she was getting worse. Full-body MRI and CTs showed nothing wrong, blood work coming back fine. Vitals appeared to be fine, but she was becoming paralyzed and couldn't eat. She had to be placed on a ventilator. Genetic testing came back negative for Prader-Willi, Engelmann, and some others. Someone on her team suspected infant botulism and ran a fecal sample and sent it to the CDC. They had baby big, botulism immunoglobulin, flown in from California and then driven 2 hours to get to us, and once she received it, she started showing improvement. She ended up having type BA infant botulism, the only case diagnosed that entire year in the United States, and she was only the 13th case of infant botulism in Minnesota ever. Without baby big, botulism is upwards of 85% fatal, but with the antitoxin, children typically have 100% recovery with no lasting side effects. Answer 19. Not a doctor, but I diagnosed a coworker's epilepsy once. We worked at a restaurant and she was notorious for being insanely clumsy and tripping, nearly falling at least 5 times a shift. I don't remember what raised my suspicions, but I asked her what she felt whenever she fell. She said it was like everything would just go white for a second and she'd lose any control of her body, but didn't think it was serious because it only lasted a second. I told her those sounded like seizures, and though I didn't know the technical name, I knew not all seizures were the big ones like you see on TV and in movies. I convinced her to at least ask her doctor about it, if only for my peace of mind. A week later, I got a huge hug and a gift basket, with her telling me I was bang on the money, and according to the doctor, they just managed to catch it and start treatment before there was any permanent damage. This was years ago, but I'm still proud of that one. Answer 20. Not the biggest medical mystery I have solved, but the first that comes to mind. I once had a 5-year-old kid come into an urgent care I was moonlighting in for cold symptoms. We talked about upper respiratory infections, supportive care, etc., examined the kid, was about to leave when I noticed one nostril was putting out purulent drainage and the other was clear. I asked mom about it and she told me that nostril always drained. She was told it was allergies. You don't get allergies in just one nostril. I also noticed that the room smelled foul. This happens a lot, so it was not that remarkable, however. It was particularly bad in this case. Any physician reading already knows what this is, I bet. So I got a little bulb syringe and suctioned out as much as I could, saw something in there, couldn't really tell with all the mucus, but grabbed some alligator forceps and reached in, pulled out a 3-inch chunk of wood. Mom was all amped up and emotional, started crying. Apparently he had this problem for a few years, saw multiple doctors and no one had fixed his problem, and because of the smell from the festering foreign body, he had been relentlessly made fun of at school. It was such a small thing for me, 15 minutes extra. The other case is not mine. It was a story a EM physician told me when I was a medical student. Had an obese woman come in with chest pain, they did all the tests and nothing came back. Finally, someone worked up the courage to do a PANIS exam under the fat pads, and this person had a wrapped McDonald's hamburger stuck up in the fat roll on her chest, and it had made a terrible dermatitis and pain. Another interesting one, kid with autism, severe food restrictions, came in with bleeding gums and tons of constitutional symptoms. Turned out to be scurvy. That was when I was a resident. Since then, I have come to find this is not so uncommon, but it sure got me excited at the time. There are so many more interesting cases, but I am getting tired of typing. This thread was nice though. Reminded me that my job isn't entirely tedious paperwork. Answer 21. One case that mystified everyone in the hospital related to a schizophrenic man with a headache. He was there for 2 weeks telling people about the headache before he got to my mental health unit. The whole time he told everyone about how he shot himself in the head with a crossbow to remove the microchip in his brain. The first time I saw him, I was like, yeah, let's check that out. I ordered a head x-ray, which is rare because it gives little more extra information than just looking at his head, and it found a crossbow bolt embedded in his skull. Surgery was called to actually fix his headache. IDK, maybe it's not that much of a mystery, but somehow it stumped like a half-dozen other doctors for a couple weeks. Answer 22. Not a doctor, but when I was working in ED as a nurse, I got a transfer from a smaller community hospital in our system. Guy was one of our cancer patients and had presented there with chest pain, and since their workup was negative, they sent him over thinking it must be treatment related. So I go in and start my assessment, open up his gown to do a 12 lead, and I'm like, sir, how long have you had this rash? I scoured the notes he was sent over with, and there was absolutely no mention of a rash even though they did an EKG there as well. I found the EDMD, who was a notorious hard ass, super unfriendly, and asked if he'd seen the patient yet, which he hadn't, and I told him, well, I think he's got shingles. He went in, checked him out, wrote a script, and off he went. Answer 23. I was on a night shift when one of my junior colleagues called me for a puzzling patient and to come and help him out. This man would be lying down and be fine, oxygen saturations 99% without any supplemental oxygen, and as he sat up in bed, his SATs went to the high 70s. So the thinking was, oh, is this an infection, a pulmonary embolism, etc., etc. It had been going on for a while, and no one seemed to know what it was. Reading the notes, lots of people had seen the patient and done various scans and got the lung specialists involved, but nothing was showing up. Out of pure luck, I had seen a case like this at a massive teaching hospital I'd worked at. This sign is called platypnea, orthodeoxia. When I first saw it, we were all puzzled, but because it was so weird and unique, it stuck. That patient had the same issue as the one I saw on this night shift and ended up having a reasonably large hole in his heart, which was repaired and his symptoms finished. Obviously, I immediately thought, surely this can't be that. It's a super rare diagnosis, but I kept sitting this man cause, then lying him down, and kept seeing the oxygen levels wildly fluctuate with exact correlation to his posture. So of course I thought, mate, fuck it. Let's get cardiology involved. Get them to scan for a hole in the heart, PFO. Lo and behold, there was one, and it was repaired, and his symptoms went away. No one congratulated me or anything, but I was absolutely buzzing that I caught that diagnosis when no one else could. Answer 24. Not a doctor, but social worker. We can't diagnose, but we can make recommendations to clients, patients, that they be evaluated for XYZ diagnosis, especially in mental health. During the pandemic, I was doing brief intervention and general mental health services. A client was describing some really intense emotional reactions to certain sounds they encounter in their daily life, and that it was really challenging for them. The way the client was describing the reaction sounded to me like neurophysiological disorder and not generalized anxiety or depression, but that's what they'd been diagnosed with. The client's doctor had been prescribing Ativan for years, but there had been no improvement in their reactions to these specific sounds. Googled the client's symptoms and misophonia was the first hit. I read the descriptions and it fit exactly what they'd been describing. I had never heard of it, but read a couple of journal articles about diagnosis and treatment and was convinced that I had to send the client some information and provide a referral to a specialist clinic in their area. This was all within about 2 hours of the initial consult. They wrote me back to say thanks and that they would check it out. Next video call was several weeks later. The client tells me that they went to the specialist and got a diagnosis of severe misophonia. They said that the clinic was very responsive and supportive and that they were getting treatment, which is mainly CBT anyway. They thanked me for validating their experience. I always felt great about that one, and it was such a simple effort on my end. Hey you! Subscribe for more histories. Answer 25. Not a doctor, but an EMT. I was called to the scene of a car accident. A man had crashed into a fence near a reservoir. He had vomited down the front of his shirt and had a large red mark on his forehead. The police were ready to arrest him for DUI and asked me to check him out. I asked him what had happened. He said he was on his way to pick up his son from school when an animal ran in front of him, causing him to swerve, hit a puddle, and skid into the fence. As he spoke, I could smell what seemed like alcohol on his breath. It was also around 7 p.m. On a sunny Sunday in July, there wasn't a puddle in sight, and there were no skid marks. His story didn't add up. I asked how much he had to drink that day. He insisted he hadn't been drinking. I pressed a little, and he said, "I'm a Muslim. I do not touch alcohol." I noticed he was very broad-shouldered and about 6 feet 3 inches tall. I asked how much he weighed. He said 375 pounds. Then I asked if he was diabetic. He said no. Had he ever been tested? No. That's when it clicked. The alcohol smell wasn't alcohol at all. It was the fruity call sign of diabetic ketoacidosis. My patient was an undiagnosed diabetic who had likely passed out behind the wheel. That explained the crash and the breath. But what about the vomiting and bizarre story? While I was puzzling that out, the man asked to go to a small local hospital. Normally a reasonable request, unless I have a trauma patient. I looked at the red mark on his forehead and decided to check his pupils, and that's when alarms went off. With help from the police, we loaded him into the ambulance and expedited transport to the nearest trauma center. En route, he complained of severe head pain, said he could feel his pulse pounding in his head, and then started screaming. His blood pressure was climbing dangerously higher and higher every time I checked it. When we arrived, the triage nurse tried to send him to general triage. I insisted he needed an immediate head CT. She pushed back. I grabbed a doctor, explained the situation, and he ordered a rush CT. As I suspected, the patient had a brain bleed. He went straight from CT into emergency surgery to stop the bleeding. It's probably the call I'm most proud of. If I had done one thing differently, if the police had arrested him, if I'd taken him to the wrong hospital, if I hadn't argued for priority treatment, or if I hadn't taken the time to really talk to him, his chances would have been so much worse. He might not have survived. Answer 26. This young person comes into the ER in an ambulance passed out. They are septic, fever, hypotension, tachycardia, and they are losing 2 organ systems at the time of presentation, kidneys and liver. They can't give a history because they are obtunded. They send this person to me and, of course, don't help me with IV contrast because they don't have sufficient renal function. The images come out looking like vague gray mush, edema everywhere. I see 4 1 to 2 millimeter gas bubbles, 1 in the portal vein, 1 in a tributary of the superior mesenteric vein, and 2 next to the pubic symphysis. These gas bubbles do not belong there and are a grim prognosticator. I have to make some kind of wild guess because this person is close to death. I look closer and see erosions on the left pubic body. I call the surgeon and tell him to cut out the pubic symphysis, septic arthritis. I make the diagnosis in 20 minutes. They cut out the offending joint, and the patient walked out of the hospital 7 days later. Follow-up CT showed hundreds of liver abscesses from bacteremia. Those cleared with continued antibiotics. My coworker who read the follow-up CT came up to me and congratulated me on a brilliant diagnosis. Answer 27. I'm giving myself away with this, shouting out my former pulmonologist who solved my medical case, at least enough that I know the why now. I suffer from recurrent spontaneous pneumothorax. I've had 10 confirmed collapses in about 7 years, but against all statistical odds, only on my left lung. I'm a woman, 37 years old. Started when I was 30. I am rail thin, but only 5 feet 4 inches. All this to say, I do not fit the criteria for who this condition impacts. I was tested for every connective tissue disorder that could be remotely related, as I do have other signs that might suggest one. But alas, all negative, even after repeat testing. I had already had a mechanical pleurodesis by the time he was my pulmo. When I needed another pleurodesis, he was part of my team and got my records and told me what my previous surgeon could have but never did. Apparently, the little sacs in my left lung are deformed in an almost diamond shape, making them prone to tearing. The odd thing, though, is that my right lung is more elongated oval and not diamond, so it hasn't torn and probably won't. I'm probably explaining this poorly. He also recognized I had untreated asthma my whole life and told me the scarring from my repeat collapses had given me COPD. He got me on meds for both. I've only had 1 minor collapse, not even a tube needed, these last 2 years since he cared enough to figure out the reason instead of throw his hands up like literally so many other doctors did the 5 years before I found him. And then he left the practice super suddenly, earlier this year, and I'm heartbroken because, I don't know, I'll trust another doctor with my life more. Fuck it, Dr. P, if you ever come across this, thank you. Because of you, I was able to work again. Because of you, I got to enjoy physical activities with my kids again. My family and I never got to truly thank you for how much you did for me, maybe without even realizing it. I can breathe again, Dr. P. I don't think you'll ever know the hugely positive impact you made on my life by just caring, and I really wish I got to tell you that. If you read this, hey doc, miss ya. Answer 28. Not a doctor, but actually a psychologist who made a life-changing diagnosis for the patient. This patient, a female of 67 years, comes into my practice one day after her physician refers her to me about having anxiety alongside vertigo that has lasted for over 12 years. The doctors couldn't figure it out, so they thought it was psychosomatic. After a brief interview, she tells me her symptoms had improved while she visited her sister for a week and immediately got them all back when she returned to her house. I then ask her about who lives with her and tells me she lives with her son's wife, and their cat. Right there and there, I think this isn't anxiety but allergies. I then suggested she try moving the cat out of the house for a couple of weeks and do a deep cleaning of the house. She returns a month later telling how she no longer feels tired all the time. Her symptoms have completely disappeared and no longer suffers from vertigo. She managed to get off her meds that she took for 12 years, all because of a cat. Gotta be honest, I felt like I docked her. House that thing right there. Might not be this huge medical mystery, but seeing her face after she had improved dramatically, her quality of life was worth it. LDR. Lady came in suffering from vertigo and anxiety. Turns out she was just allergic to her cat for 12 years, and no one noticed until I made the connection. Answer 29. I actually just figured one out. I've never been allergic to anything, never had eczema, no notable issues or problems. Skin-wise, that was until the end of December this last year. I started getting really dry patches on my eyelids that slowly got worse to fully red and flaky skin that had also spread around the edges of my face. It was so painful, and I had no idea what it was. Finally got into a dermatologist and she gave me some cream because she immediately clocked it as contact dermatitis caused by an allergic reaction. The cream helped, but whenever I stopped using it, it came back. So I went in, and she told me I had to do a patch test. To make a long story shorter, my insurance me and I couldn't get it then, so I had to get it sorted, and then wait so long to get into another office just to get a patch test. Anyways, the result was, I am incredibly allergic to nickel. Honestly, I wasn't too surprised because while I didn't think was allergic to it, I knew I was at least sensitive, so my jewelry is nickel-free. But my fucking glasses aren't. This whole time, the reaction has been from my damn glasses, and it's crazy to me.
That was enough for today, Cosmonaut. I'll wait for you in the next travel.